Hello everyone and welcome back to our another video based on epithelial dysplasia. Welcome back to Last Night Dentistry, and today we are going to cover another topic important for your exam preparation. So before starting, I got a scenario for you guys. Just listen to it and then I will tell why I have asked this scenario in the start. So imagine a patient comes to your clinic with a white patch on the side of the tongue. Firstly, it looks harmless. No pain, no swelling, nothing dramatic. But microscopically, the lesion may already be taking the first step towards oral cancer. And that premalignant stage is called epithelial dysplasia. So, in today's video, we will understand epithelial dysplasia and carcinoma in situ in the simplest possible way for exams, viva, and your clinical understanding. So, moving forward to the definition. First, let's understand the definition. Epithelial dysplasia is a premalignant change in epithelium characterized by both cellular and architectural abnormalities. Now, what does that actually mean? It means the epithelial cells start losing their normal behavior. They begin changing in size, shape, arrangement, and growth pattern. This is not invasive cancer yet, but the tissue is moving toward malignancy. So, dysplasia is basically the transition stage between normal epithelium and carcinoma. Now, moving towards the disease progression. Now, let's understand how cancer develops. Oral squamous cell carcinoma usually does not appear suddenly. It develops gradually over time. Normal epithelium first develops mild dysplasia, then moderate dysplasia, followed by severe dysplasia, then carcinoma in situ, and finally invasive squamous cell carcinoma. This progression may take months or even years, and smoking greatly accelerates this process. That is why chronic smokers with persistent leukoplakia are considered high-risk patients. Moving forward to the cellular alterations. Now let's move to the microscopic cellular changes. These are extremely important for exams. One of the first changes is hyperchromatic nuclei. That means the nuclei become darker because of increased DNA content. Then comes nuclear pleomorphism, meaning the nuclei vary in shape and size. You may also see prominent nucleoli and increased nuclear to cytoplasmic ratio and increased mitotic activity. Sometimes the mitotic figures even become abnormal, and multinucleated cells may also appear. All these findings indicate loss of normal cellular control. Now, coming at the architectural alterations. But dysplasia is not only about individual cells. The overall architecture of the epithelium also changes. You may see bulbous rete, basilar hyperplasia, hypercellularity, and abnormal maturation of keratinocytes. In simpler words, the epithelium becomes disorganized. The normal orderly maturation pattern starts breaking down. So, now moving at the clinical presentation. Clinically, how does epithelial dysplasia appear? Most commonly as leukoplakia, a white lesion that cannot be scraped off. Sometimes it may also appear as erythroplakia or a mixed red and white lesion. The most dangerous sites are the lateral border of the tongue and the floor of the mouth. These are the high risk areas for malignant transformation. And clinically, dysplastic lesions may look very innocent. That's what makes them dangerous. Now moving to the Grading of dysplasia. Now let's discuss grading. Dysplasia is divided into mild, moderate, and severe. In mild dysplasia, changes are limited mostly to the lower one third of epithelium. In moderate dysplasia, the middle layers become involved, and in severe dysplasia, most of the epithelial thickness shows abnormal changes. Now, here's the important concept: the higher the grade, the greater the malignant potential. Some mild dysplasias may regress if the patient stops smoking, but moderate and severe dysplasia are much less likely to reverse. Now, coming to carcinoma in situ, one of the most important viva questions. Carcinoma in situ is the most severe stage of epithelial dysplasia. The entire thickness of epithelium becomes dysplastic, but the basement membrane is still intact. This is the key point. No invasion into connective tissue has occurred yet, but once the dysplastic cells breach the basement membrane, it becomes invasive squamous cell carcinoma, and now metastasis becomes possible. Coming to lichenoid dysplasia. Now let's discuss an important confusing topic: lichenoid dysplasia. Sometimes epithelial dysplasia shows a dense lymphocytic infiltrate, making it resemble lichen planus. This can create diagnostic confusion. Some lesions initially diagnosed as lichen planus later develop carcinoma. Sorry for that. So researchers question whether those lesions were actually dysplasia from the beginning. Today, genetic studies suggest that true oral lichen planus usually follows different molecular pathways, but histopathologic interpretation well still remains very important. Now, coming at the summary of this entire topic is epithelial dysplasia is a premalignant epithelial alteration. It involves both cellular and architectural abnormalities. It commonly presents as leukoplakia. Smoking is the major risk factor. Mild dysplasia may regress, but severe dysplasia carries high malignant potential. Carcinoma in situ means full thickness dysplasia with basement membrane still intact, and once invasion occurs, it becomes squamous cell carcinoma. So, clinically, never ignore persistent white or red lesions in the oral cavity. If the video helped simplify epithelial dysplasia for you, kindly subscribe for more oral pathology concept explained clinically and exam wise. And I will see you in the next lecture. I hope this lecture will definitely help you, and if it does, please give me a subscribe and just share the video so others can get help from it as well. I hope I'm just helping you in some way. Thank you.